So I'm Dr. Robert Yielding. I'm a psychologist in practice in Newport Beach, California at the Anxiety and Depression Center. And I wanted to talk briefly today about a growing challenge, at least where I am, which is cannabis use as a treatment interfering behavior in the context of social anxiety disorder. So here's where we're at in terms of legalization right now. Welcome to California. I think that the experiences that I've had are going to be, if not already, some shared experience growing into the future. I think most recently Michigan, and then I think I heard earlier that tomorrow the country of Canada officially goes into play with legalization. And it's not that cannabis is new to California or many of these other places too, but there is many new legal and especially, which I'll talk about, commercial forces and social forces that are becoming growing challenges. So, quick state of the research, as if you've participated in any of the other talks around cannabinoids this weekend, it's very limited. In terms of actual conclusive evidence to guide policy, there's really only these three categories: the treatment of chronic pain in adults, the treatment of chemotherapy-induced nausea, and for symptoms of MS. So if I were back home with my patients, or friends for that matter, I would already have a problem here. There would already be surprise, maybe some anger, some references about CBD or marijuana for anxiety, insomnia, healthy skin, healthy hair, my dog's anxiety. This is what's really happening. So, the actual state of the evidence is just plain and simple, still in its infancy. There's limited, in terms of a category of limited evidence that cannabinoids are, in their wording, effective for improving anxiety symptoms. But even the very initial studies showing this need to be really looked into in terms of the interpretations that were taken away from the research findings. For example, here's a very commonly cited research article that took two groups of individuals with social anxiety disorder and engaged them in a simulated public speaking task. The treatment group was given a single dose of CBD prior to the task, and the outcome was that they reported decreased symptoms of anxiety, as well as some decreased physiological measures such as lowered heartbeat. The group who took the CBD dose. So, effective for helping with anxiety. Or, what we also have as a way of thinking about this is a group of individuals with a social anxiety disorder diagnosis who engaged in an exposure task and took a substance to diminish their experience of anxiety and physiological activation. Any guesses about another way of describing this might be? So this is one challenge to be aware of. Is good that research is starting, but always holding in mind, or really asserting the need for a more complex understanding of what the findings are coming out with. So the bigger problem is that now that it's legal, there's all kinds of new commercial and marketing forces coming into the fray. So these forces have really created a big gap, which I've hinted at a little bit already, between the proposed benefits and the actual state of the evidence around the therapeutic health effects of cannabinoids. So I wanted to just give you, I could have found many, but a couple examples of what this looks like. This is a website grab that I found online pretty quickly, which is on a particular dispensary's website. And you can see in the center, it's an anxiety-focused marketing. It says Conquer Social Anxiety. And what you're going to find below are the 6 recommended strains that they're selling for in this case, social anxiety. So you have the silver haze, the orange crush, and the power plants for the social anxiety at the party or going to class, whatever it's going to be. One other example, I took this picture while driving around in LA the other day, and you can see it's a poster board. It says anxiety ? And then there's an advertisement for that particular dispensary's online website. And these are pretty much starting to replace the just anecdotally majority of posters around different parts of LA. Has anyone else seen these in different states, or is this pretty couple? Yeah, okay. So we put all this together, and we have a growing challenge with problem recognition, and patients, as if they didn't enough already, increasingly viewing cannabis as an adaptive way to cope with anxiety, especially social anxiety. I don't know if anyone else was able to go to the talk yesterday about anxiety disorders and substance use disorder, but one of the things the presenter mentioned was that a lot of people showing up for treatment didn't even report their marijuana or cannabis use because it was so normalized they didn't even view it as a drug to report, showing up, and they might not even think about it that way at this point. So this will be a challenge for anxiety disorders in general, but it's a particular challenge for a very vulnerable population, which is those with social anxiety disorder around cannabis. So briefly on the research, there's evidence that frequent regular cannabis use, that means daily to every other day, increases incidence or is a risk factor for social anxiety disorder. On the other hand, having social anxiety disorder is a risk factor for developing cannabis-related problems. In particular, you can see 1/3 to 1/4 of people with cannabis dependence have social anxiety disorder, higher than any other anxiety disorder. So the cannabis and the social anxiety, one becomes a risk factor for the other. There's an association. How to break it apart from there, I'm not sure anyone knows at this point. So this is our challenge. As cannabis use becomes increasingly normalized, even idealized, it becomes imperative that for every social anxiety disorder patient, we not only assess cannabis use, but we need to work collaboratively to really conceptualize the function of cannabis use or the multiple functions of cannabis use. One of the most helpful models that I found to help with that is Buckner's biopsychosocial model of social anxiety disorder and substance use disorder. And you can see these are the most commonly found functions, coping motivated behaviors around social anxiety disorder. So for example, a patient might be utilizing a function of avoiding social evaluation. They might say something like, if they were to tell you this, that I got high before the party, so then I had an excuse not to go. Or I would rather go smoke somewhere to avoid that particular interaction. Or they might use it for social facilitation if they're underestimating their social skills. If I don't get high, I won't be able to talk to anyone. They might use it for managing physiological arousal. They may have fears related to physiological sensations that without using the cannabis, they're going to become ill, or their anxiety will become too visible. All kinds of different fears that can come up around it. And this is often a growing, hidden, treatment barrier going on if we're not looking out for it. It not only likely interferes with the learning needed to progress in treatment, but over time, with over-reliance on these coping motivated behaviors, we can wind up with a substance use disorder on top of the anxiety disorder, the social anxiety disorder. So just to bring it to life a little bit, here's a brief example of a typical patient I have seen, many typical patients like this. So this is a 20-year-old male college student. He's on a leave of absence for a semester due to progressing isolation and social anxiety that eventually got in the way of him being able to attend class and fulfill his requirements. During the initial assessment, the patient reports cannabis use by vape pen on a daily to every other day basis. He reports cannabis use increases his social enjoyment and helps ease gastrointestinal symptoms in social situations. So already we have some ideas about the likely functions of use for this patient. He also reports a structure to his cannabis use, where he would utilize different strains and dose varietals, the quantity of THC versus CBT, indica, sativa, etc., perceived as helpful for different task demands. He will have one combination of use for if you wanted to attend a party, what would be perceived as most helpful for that, versus what would be most helpful for assisting sleep onset after the party to downregulate. So what do we do? As I've already been discussing, through assessment, we're collaboratively working to have a shared understanding of the likely functions of use for the patient, the perceived benefits and potential costs. We're providing psychoeducation regarding the maladaptive functions of cannabis use over the long term, especially within the context of a treatment conceptualization, such as the CBT conceptualization you're working with the patient, and working to establish a goal consensus of altering the maladaptive use that's interfering with learning, being used as a safety behavior, and developing alternate coping responses to allow new learning to occur. So how do we do this? One way is through, that I found really helpful, a specific behavioral hierarchy or exposure hierarchy. You can work directly targeting the maladaptive cannabis use. So what this is going to look like, or what you want to have on this hierarchy, is behavioral goals that look to delay the onset of use. For example, can we set a target of tolerating being in the social situation for cannabis use and increasing that amount over time? Can we set a target of delaying onset of use after the initiation of anxiety symptoms and increasing that over time? Different steps of reducing the frequency and quantity of use. Depending on what's being used and the functioning of it, we might work towards altering dosage as a step along the exposure hierarchy. For example, if a person always uses primarily THC in a particular social situation, as one step along the fear ladder, we might look towards switching that to CBD. And of course, we're looking to develop alternative coping behaviors and then eventually begin experimenting with beginning situations without use at all. And of course, probably review, but in each of these exposure steps, we're looking to identify the goal of the experiment, in particular related to one of these examples. Identify and draw out the patient's automatic thoughts, predictions, underlying assumptions. If I weren't to smoke at the party, then what would happen? What is the underlying assumption or belief that we're looking to test out here? And always looking to reinforce new learning, grow distress tolerance, and the perceived ability to cope without the short-term benefits of cannabis use. Assuming they even offer those. Sometimes this backfires. I think with THC especially, there's this dose-response continuum where, in general, small amounts would lead towards an anxiolytic effect, but if you overdo it, you're going to be in big trouble. It actually has, the opposite effect, and then they're really not going to be having fun at the party at that point. Okay, so to kind of wrap up with the case example, for this particular patient, we conceptualized cannabis use functions, primarily of managing physiological arousal in social situations. He had a feared outcome that if I were not to use cannabis, I would become ill or I would need to urgently use the restroom enough that I might have an accident and then therefore suffer humiliation, socially. And he also used it to manage evaluation fears. He had a group of friends that also primarily smoked consistently, and there were automatic thoughts of social rejection for not using. So with this particular patient, we established a behavioral experiment hierarchy to target, as one of them, to target and alter the function of use and to test and alter the beliefs associated with them. For example, we practiced delaying in increments of 15 minutes after the onset of anxiety symptoms before he would use. So for example, this week, he's practicing waiting 15 minutes after he feels anxious before he's allowed to smoke. The next week, he's increasing it another 15, while also practicing alternative coping responses in the meantime. We also practice altering the dosage of use. So for example, he was eventually able to start in some situations and only use CBD when he would typically be using THC as a stepwise as one step, towards eventually not using it at all as a safety behavior. And eventually we began exposing to situations with shorter time length with no use, while also practicing utilizing coping skills. For him in particular, he found once he noticed some physiological activation and some anxious thoughts about it, practicing utilizing externalized or external attentional focus, back into the situation, he found really helpful. And overall, his cannabis use didn't stop. It continued at probably a healthy dose. But we were able to find at least enough alteration of the function of use that, along with other treatment targets, it was able to free up the opportunity for learning, the opportunity for exposure, which led towards being able to progress towards treatment goals enough at least to be able to return back to school. So just to summarize up, a few main points here. There's already is, and if you're not already experiencing it, there's going to be a growing normalization of cannabis, which is already leading towards patients increasingly viewing it as a positive coping behavior. They might not even report it. They might come in kind of thinking they're doing a good job using something in that kind of way. So we need to assess cannabis use in all social anxiety disorder patients, including working collaboratively and patiently with the client to understand the specific functions of use for that person. And of course, we need to target through interventions such as an exposure hierarchy, the maladaptive functions of use that interfere with exposure and the learning needed for treatment to then hopefully progress and overcome this challenge. So I think here's my information if everyone wants to follow up with anything, but we have some time for questions.
Maybe we can start. I think somebody had a question for Randy Wise. Yeah. You want to answer, Randy? No problem. There you go.
She's a taskmaster. Yeah. Well, and after everybody, that was great. So my question was about, I work with youth who often experience social anxiety, and I have a couple clients who actually refrain from social media altogether because of social anxiety. Okay. And I've often hesitated to recommend that they go on social media, in part because I think the parents I work with would kill me. But it does seem like an important part of being a social being in this culture, right, that you're just avoiding altogether. So I just was curious to hear your thoughts on actually encouraging clients to get on social media and then do those social media exposures that you discussed, and then...
Are these adolescents? Or? Yeah, which I don't treat, but my first thought would be that that's normative for them. And so their complete, abstinence is inhibiting their participation with their peer group, right? And so you might want to educate the parents why the use of social media might actually, in this case, be beneficial, but you would want to introduce some balance to your teenage clients, right? And look at what is it they're afraid of? Is it like my case with Anna? Why are they holding back? And target that and see if that would be, and also how are they interacting face to face? So can it be a transition like I'm describing? Does that answer?
Yeah, absolutely. Yeah.
Okay.
Yes.
My question is for John about trying to keep people in treatment once they start. I do groups with people with social anxiety, and of course, as you know, it's like herding cats to get them to enough people to actually start. But how do you deal with the financial contracts? Do you ever say you have to pay for all the sessions in advance to increase their motivation to stay in? Or?
Well, I think that's a really good question, and I've spoken to numerous people who do these groups all over the country, and I've heard different formulas throughout. What I personally do is I spread the cost of the group. It's a 10-week group over the 10 weeks. So they're not paying it all up front, but they're paying it in increments. And if they leave the group without saying goodbye to the group or without us trying to work on helping them stay in the group, then they're penalized by having to pay for 4 sessions
But they've gone. How do you get them to pay?
Oh, I only take credit cards for the group clients. Yeah, but and Robert mentioned at his clinic. Do you want to speak to that?
Sure. No, I'll talk briefly. So I do what you're describing for groups, which is require full payment before the start of the group for the entire group, start to finish for the 12 weeks, for example. My feedback would be that it is very helpful with retaining the clients who were able to get in, but it's harder to get the numbers to start. So it's pluses and minuses, definitely.
Oh, yes, at the back.
I had a question. One thing I've experienced at my practice is severely socially anxious people who fall in love with people online. And sometimes it's things that are clearly nefarious, like FilipinoHeart.com. I'm serious. And do you have any suggestions or recommendations for handling that? Because we found it very difficult. So the person's feeling in love. In a couple cases, they're engaged. And they have never yet had a face-to-face meeting, and they're convinced of the amazingness of this relationship, and it's just a very difficult, delicate situation.
Boy, that's a tricky question, Karen. There must be so many situations like that are now part of this culture that we haven't even really considered until we run across them. I think I would be trying to go toward, at the very least, some meeting and some reality testing, and some way of, perhaps some way of interacting that isn't online. Are they in different countries, or?
With the three that I'm thinking of, they're all in different countries, and with two of them, this hasn't happened yet. The time when they're going to meet is when they're going to get married.
Wow.
And so I've been trying to negotiate, like what you're saying is, could we have some kind of meeting before you're in over your head? But they're kind of,
I think the problem here is that there is no anxiety at all, it looks like. It's the opposite.
Well, actually, see, all three of these are people, they don't socialize face to face, and they have horrible social anxiety disorder that generalized, but they've created this identity, and so it's I think you used a nice word, it's very idealized, and they're people who don't date, they don't have practical experience with the rough and tumble of getting to know people.
Right. So this is an easy alternative, they think, but they have no idea what awaits them. And I was sitting here thinking maybe you could persuade them, or get them to try interacting, just to I don't know, maybe are they going to have a wedding? Is there going to be social anxiety around the wedding? Is there any way to get them to interact with people before?
Maybe FaceTime?
Yeah. Are they FaceTiming with these? Are they seeing? Yeah. It's an idealized, and this gets us into the whole issue, in my opinion, of friends. All these so-called friendships, which of course aren't really friendships. And this is like the most extreme example. So that's a tough one.
Adding on to that, it's a cautionary tale for human trafficking. Very much so.
I can say one thing. You also might want to look to maybe some educational online references. I don't know them off the top of my head, but I know there's a lot of good stuff out there now around safety and catfishing and all these other things that might be going on. So that could be a good, yeah.
I hadn't thought of that. Anybody else?
Yeah. Randy, I was wondering if as part of the exposure, do you follow your patients on Instagram and so on and so forth so that they can...
I was hoping nobody would ask me that. No. No, I don't.
Because I would think that would add to it if you were seeing what they were putting up.
Yeah, I don't. Yeah, and the perfectionism, I don't do that. Okay.
I put in my informed consent and say in the first session that I don't interact with any clients on social media. I hear that that's becoming more of a common practice, but I verbally say it, and it's also written in the informed consent.
Yeah.
I would just say I work mostly with teens and young adults, but if I have a social anxiety client, I begin my intake by just saying, I know this is your worst nightmare. And I can't tell you how it changes the next hour that they know I know that this is terrible for them. And I think we all would do better to check about Alliance regularly, but when you spoke about the Alliance issues, I think there's a modeling thing that also comes to say it's impossible for most people to tell a therapist, right, if you're doing well or badly, but you won't hurt my feelings. You'd hurt my feelings more if I didn't know, like, that I was getting wrong with you. I just think I do extra of that with socially anxious clients because of the engagement and retention. So I just think I really appreciate you bringing that up. I think it's really important. Even if you do that, it doesn't guarantee anything, but it helps.
Thank you for making that point. And of course, as CBT focused as we are, you know, we ought to be, as a routine practice, eliciting feedback. But you know, your point's well taken that if they're afraid to give that feedback, we have to make it really extra comfortable for them to do it.
Anybody else? No? I think we're done. Thank you.